And welcome to the Dr. Bob Show. Hearing loss in the United States is a huge problem. It's frequently associated with the development of depression or lack of social skills. There's even an increased incidence of dementia in people that have hearing loss. What are the causes of hearing loss, and what can we do for those? We'll be answering those questions on this Dr. Bob Show. My guest is Dr. Jameson Mattingly. Dr. Mattingly is a board-certified ENT physician, otorhinolaryngologist, who's double-boarded in neurotology in the ear. And we're going to be learning about what can go on in the ear that causes hearing loss and the many things that we can do to correct it. I can't wait for this show. I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about how good health includes making sure your hearing is in good shape. You'll want to stay tuned. We're talking with Dr. Jameson Mattingly, board-certified ear, nose, and throat specialist, double-boarded in neurotology and predominantly the ear. And we're going to be talking mainly about hearing loss. Welcome to the Dr. Bob Show.
Thank you for having me, Dr. Bob. Pleasure to be here.
How important is hearing loss in the United States?
Well, it's very important. I mean, I am biased because I take care of a lot of patients who have that problem. With that being said, what I've noticed mostly is that we have a lot of people who struggle with communication on a day-to-day basis because of that. And that's probably where it starts. There's a lot more complicated ways we can go into that, and some good information coming out about depression, social isolation, dementia, that really, I think, can kind of bring that home as far as the medical importance of it.
So how does a person know if they've got hearing loss? Somebody tells them, or there are some keys to it? What do you look for?
That's a great question. I laugh because I have that question all the time. And most of the time, people come because someone else tells them. It's usually a spouse or a loved one that says, hey, I'm having to repeat myself frequently, or they just don't seem like they're getting as much, the volume on the TV is rising, and so it's frequently another person. Most people are pretty poor judges of their own hearing, usually, I would say.
Yeah, and my wife recommended one time that, Dr. Bob, you might want to go get your hearing checked. You don't seem to be...
How long did it take you?
She encouraged me pretty quickly, so it didn't take me too long to get that done. And it was a wonderful experience learning more about my hearing and how important that was in my life. Are there different types of hearing loss?
There are. There's kind of two ways I break that down. The inner ear, there's an inner ear style of hearing loss where it's the nervous system, the neural part of your hearing, and then there's what's called a conductive type of hearing loss where usually it means that the eardrum or the ear bones are a problem. There's a third type that's called a mixed hearing loss where it's a combination of the two, where there may be a problem with the ear bone or the eardrum, and there's also some inner ear damage of some sort.
So when you talk about the eardrum and the ear bones and the inner ear part of the hearing, walk me through that.
Okay.
Walk me through the canal and the eardrum and the bones that are there, how they work.
Okay, yeah, excellent question. So the outside of the ear, is actually the most basic part in a lot of ways. It's mostly just funneling sound to the ear. The ear canal is the same way. It's a cylinder, and it just allows the sound to become more focused. And then it hits the eardrum. The eardrum is this kind of tense structure, and it's tightly adherent to the first ear bone. And when that eardrum vibrates, it vibrates the first ear bone, that vibrates the second ear bone, that vibrates the third ear bone. And that basically sends a pressure wave into the inner ear. And that's really when the more complicated aspects of hearing begin. With that being said, what I just walked through is very simplistic on actually how it works. But for the most part, most of the hearing begins in the inner ear, which is called the cochlea, the inner ear hearing organ.
So that's the hearing organ, is the cochlea. What's the cochlea like? What goes on in the cochlea?
Well, it's a spiral. It looks like a snail.
Yeah.
It's actually oddly reminiscent of a snail. And when you get into the cochlea, there's these hair-like cells, and what they do is they move in response to pressure. And that pressure is usually coming in at a different frequency, and that frequency is actually what stimulates the hearing nerve that then goes to the brain.
What goes wrong with the cochlea?
Lots of things.
So the little hair-like follicles, they get damaged?
They do. They frequently get damaged. You can have damage in any kind of part of that process, but I would say the cochlea, for most people, that's where most of the damage, and that can be aging, toxic compounds, noise, genetics. There can be a ton of things that cause damage to that structure.
So is noise one of the biggest ones, or are there other big causes of hearing damage in the cochlea?
Two of the most common that I see are aging and noise.
So we can't prevent aging.
Can't prevent aging. Most people say, what can I do to prevent my hearing loss? I'm like, well, unfortunately, we just need to monitor it and treat it as it comes. Noise is something that is modifiable. Unfortunately, thankfully over the last several years, there's been a little stricter regulations on what people in the workplace, for instance, can do from how much noise they can actually be exposed to. But that doesn't stop people from going out into their hobbies, whether that's, gunfire or explosions, if they're in the military, things like that can actually cause a lot of hearing loss that they may not even notice until later on in life.
How about blenders and motors that are in the kitchen? Do they produce enough dangerous vibration decibels?
Not generally. There are some criteria that we can use, and most of the time, noises that you don't hurt and they're only for short periods of time are generally not a big risk. A sound loud enough, like a jet engine or a gunshot, can instantaneously damage the ear, but usually we're talking about prolonged periods of elevated noise exposure. That's really the risk.
When the noise damages the ear, what's the mechanism of damage?
That's a great question. It's mostly what we call a metabolic damage, where there is enough of a trauma from the sound wave itself that it can actually cause some basically damage to the nerve fibers and the actual hair cells that basically almost becomes toxic to itself in some way. And at first, when you first start this, especially if you're young, you may not notice this at all, and it may just cause it to be more advanced later on in life, or you may get hearing loss earlier than you otherwise would expect.
So if you get exposed to a loud noise, a gunshot and sudden explosion, something falls near you, some blast of noise, music too loud that's there, why do we get ringing of the ears sometimes with that?
Well, ringing, the better term for ringing from my standpoint is tinnitus or tinnitus. Ringing is very poorly understood with respect to hearing. We know that usually there's damage to the ear. That means there's hearing loss, and ringing comes along with that. We actually think that it's a central process, meaning that it's from the brain itself. And there's some pathways that can kind of get disorganized, so to speak, and they actually go through some unpleasant centers of your brain, and it causes you to have this noise, and it can be very unpleasant. But it's hard to know exactly where in the process that happens, but generally speaking, it starts with the ear, but we think it's actually made by the brain or a combination of the brain and the ear. It's a very relatively poorly understood process.
Can you treat tinnitus or tinnitus?
You in theory can. In practice, it's a little bit more difficult. There's certainly no cure. There's a lot of people or a lot of things out there that suggest a cure, but in general, it's very difficult. And really what we're trying to do is to drown it out, to mask it, or to help people cope with the annoyance of it. And generally speaking, it's not dangerous, and it usually, once I give people some assurance that it's nothing dangerous, that's usually enough. And there occasionally are some people who are more disturbed by it, and we have some more intensive things we can do, but unfortunately, not a great cure, but a lot of things we can do to help cope with it or make it less severe.
What are some of the clues that a person has that lets somebody else know or lets them know they're getting hearing loss?
Yeah, I would say communication, how they're doing day to day.
Well, what communication problems?
Usually at work, with your family, it's usually needing to repeat themselves. Maybe things aren't clear, or maybe the first time they notice it is they're saying, you know what, I really don't want to go out to eat tonight because it's noisy. and I can't hear anything anybody says. And it doesn't dawn on people that maybe it's my hearing that's the problem rather than it's too noisy. Because many years ago they may have done just fine in that scenario. But I think frequently it's other people, or they say, I'm just not performing like I used to because I'm missing things, or saying what, or huh, or maybe I have one good ear, one bad ear, and I have to position myself a certain way in order to really maximize how I'm doing with that.
So there's really lots of clues that you can look for to determine whether or not there's a high likelihood of having hearing loss.
So, very rarely is there like complete loss of hearing, and that's very obvious. It's usually gradual. And then when there's gradual change like that, it becomes more difficult to actually assess that yourself, I would say.
Is it easy to test hearing and hearing loss?
It's very, very easy, very straightforward.
And that's what we're going to be talking about when we come back. It's very, very easy to test hearing loss. If you think you have it, maybe we need to get it tested. We're talking with Dr. Jameson Mattingly, and we're talking about hearing mechanism, the things that can go wrong with hearing, and how to recognize early that you may need to have your hearing checked, because there's lots that we can do for it. So tell me about a hearing test. What goes on in a hearing test?
Well, there's a group of people I work very close with called audiologists, and they're professionals who do things like hearing testing, they do hearing aid fitting, and they do other more sophisticated hearing imbalance testing. But from a basic sense, one of the things they do mostly is do hearing tests. And you put you in a booth that's relatively soundproof, and they go through a range of frequencies and tones that basically give us a good sense through the the kind of general frequencies that are important for speech and things like that, how you're doing with respect to the average person.
What are they looking for, the audiologist, as far as helping the ENT physician in developing good hearing? What are they looking for? Certain frequencies, or what noises?
Yeah, they're looking for certain patterns of hearing loss, low frequency, high frequency.
What do those mean?
They can mean a variety of different things. I would say the most common thing we see is high frequency hearing loss. That's in a lot of different disease processes. That's the first thing that actually is damaged. There are some other patterns where people can have low frequency hearing loss that suggest certain diseases versus others. And I would say that's more uncommon. But for instance, normal aging is high frequency hearing loss typically. They're looking at that. They're also looking at their clarity of sound. So once they understand basically where they're hearing, they test their ability to recognize words. And that's kind of what I'm most interested in. Is I don't care if you can hear the dog bark or the alarm clock go off. I care if you can hear words. And that's where we get a sense of, okay, so with their hearing's at this level, does the clarity match that, for instance? And sometimes that can help us be more aggressive with hearing aids or discuss other things that may be more useful for a patient if their hearing loss is that bad or something like that.
So there are different things you can do to make words sound more clear, more distinct, more easily interpreted.
For the most part, most people, the standard hearing loss is usually just giving them volume, and that's what a hearing aid, for instance, can do. It's more sophisticated than that. They can actually do a lot of things with hearing aids that makes things more clear. They're looking for better clarity, but in general, they're looking for, is this person, if I give them just volume alone, how will they do? And that's a very important thing, because most people who have the hearing loss, all they need is some extra volume for the most part. It can get more complicated than that, but generally speaking, that's what we're looking for.
Years ago, when I would see patients that had just received a hearing aid, the problem that they were saying at that time that it made all noises too loud, and so you still had to differentiate the different noises. Let's go back to high frequency noises. Is there a certain part of the cochlea, the hearing organ, where high frequency noise comes from?
Absolutely. It's called the base of the cochlea, and when you get into the ear, there's two windows for the cochlea. There's one called the oval window, which is where the stapes, the third ear bone, connects. And there's the round window, which is kind of just next to it, but it's sort of like a pressure relief valve for the actual cochlea, but it's right where the high frequencies start. And we think that because of its proximity to sounds coming in and to any kind of toxic things, it has a tendency to be affected first. There's a number of things that go into that, but in general, for a lot of disease process, the high frequencies are what are damaged first.
So if somebody's having the little hair follicles that are moving because of vibration that comes in through the windows, is there a certain stiffness that can occur in those hair follicles? Can they be diseased themselves?
So the hair follicles don't change in stiffness, but the actual what they sit on can, and that's what actually gives you the difference in low frequencies and high frequencies to some degree. And so, you know, when we go into physics a little bit more, the stiffness of an object will sometimes tell you about how sound conducts through it. And for the most part, that is at least partially explains how we get frequency selectivity when our sounds, and that's really how we differentiate or tell the difference between different words and different sounds and things like that. And that's where we talk about the mechanics, the structure of the actual cochlea. So you're getting pretty deep here now all of a sudden. So it's
getting more and more and more sophisticated and better and better and better. Sometimes you can control certain aspects of the hearing aid with a cell phone.
Correct. And we can do stuff in the office, the audiologist can, to shift the frequencies if you do particularly poor in one area, or just amplify certain frequencies if they're affected. Or we can do things like Bluetooth, where you actually get a higher signal to the outside noise. There's a lot of things we can do to make things more clear.
That must be a great feeling, to be able to help different aspects of hearing difficulty that a patient has. As the hearing gets worse and worse, sometimes hearing aids just can't handle what's needed.
That's correct.
And when that happens, what do you do? It'd be profound hearing loss. So what are the options at that time?
Yeah, so that's something that's near and dear to my heart, or anybody who does a field like me. The hearing aids I deal with regularly, but really what I'm most interested in is what happens when people don't do well with a hearing aid. And that usually means the clarity of their sound is not where they want it to be able to communicate on a day-to-day basis. And that's when we start thinking about other things like a cochlear implant. And a cochlear implant, we can go into more detail, but that's really the next step for someone whose clarity of sound, or they're really struggling with hearing aids that are properly fit.
How does the audiologist pick it up that you're getting into severe loss with lack of clearness of what the words are and how intense the words are? Can they detect that with the computer sound waves?
Not really. A lot of that testing is a patient response. For instance, if we go into a standard hearing test and they're going through the tones, and they have tones that are, let's say, moderate to profound, or in that range, or their ability to discriminate words becomes, let's say, less than 50, 60%, maybe even higher in some cases. Once you get to that, we start to wonder, are we amplifying just noise? Are we amplifying words? And then it's really asking the patient, like, how are you doing? Are you struggling? There are some other tests that we can do. We don't do them very commonly for hearing aid testing, like how do you do in sentences or how do you do with specific words. But a lot of it is hey, I'm not getting the results that I think I should be with a hearing aid. I'm still struggling at my work, with my family. Is there anything else? And that's when we say, okay, are you someone who could benefit from a cochlear implant?
So since the cochlea is the hearing organ, you can put in an artificial hearing organ in the ear. Is that what a cochlear implant is, basically?
Basically, it is.
Pretty naive
That's
statement.
probably the best way to describe it I've ever heard, actually. So no, it's an electrode, and so it's electrical, and we stick it into the cochlea, and it wraps around, and it goes through the different frequencies of the cochlea. And what it does is it bypasses the most common areas of damage, which is usually within the cochlea we talked about earlier, and it essentially stimulates the hearing nerve itself.
How big is that cochlea?
It's very small. It's probably somewhere around 3 centimeters in length, maybe plus or minus some. So 3 centimeters.
Maybe like the end of my finger,
yeah,
a fingernail?
So something like an inch or two, yeah.
And can you see the appearance of the snail-like circles that are in the cochlea?
You can see part of it. It's hard to see in surgery or in real life. It's hard to actually appreciate that, but you can see part of it, and it's very three-dimensional. It's a very difficult aspect of the training, is understanding this complicated structure in real life. But you can make out that it's making a spiral for sure.
As I was increasing my knowledge in medicine, and was learning the word cochlea and was learning the word cochlear implants, it was my initial impression that these were people that were severely impeded in their hearing at birth, and they just really had the inability to hear well. And a cochlear implant would allow them to hear. But what I'm hearing us say today is our hearing can start becoming damaged and get worse and worse and worse where even at age 60 or 65 or 55 or 75, you can implant a cochlea and you can change somebody's life with hearing.
Absolutely. I mean, there's very few, there's not really many ages that aren't included in a cochlear implant. We really don't do it earlier than about 6, 8, 10 months of life, but then there's really no up end, there's no ceiling to that. I mean, I think I've done a cochlear implant on like a 10-month-old to all the way to 94, I think is the oldest one I've done.
Wow.
So, you know.
So I'm still eligible? I think.
I won't comment one way or the other. Yeah, absolutely. If you're struggling with your hearing, you're absolutely a candidate because, you know, we know that it has significant quality of life benefits, and we've already talked about some of the medical issues of depression, anxiety, social isolation that can really be enhanced by someone who can hear. And that's the best thing we have for someone who gets to a certain level of their hearing loss.
So I want to talk about the procedure, how a cochlear implant is implanted and what the follow-up is and how you develop hearing, and if you have to train that, if you have to have physical. I got a million questions.
Good.
We're going to come back and answer those in just a minute. We're talking with Dr. Jameson Mattingly, and we've been talking about hearing loss and the importance of detecting hearing loss and getting it corrected. If hearing aids don't do the job and the hearing loss progresses, then we walk into the hearing organ, cochlear implants, and that's where we are now. Let's talk about how is the surgery done?
It is an outpatient surgery for most people. They go home the same day. I usually make an incision, or always make an incision behind the ear, and I actually, you know, more than anything, make a pathway from where I put the implant under the scalp to the inner ear, where we actually put the cochlear implant into the cochlea itself.
So do you have to go through some bone, some skull?
We do. I was kind of trying to avoid that portion of it, but yes, we have to drill through some bone.
Yeah.
But it's a common thing I do for a lot of different surgeries, and people don't miss that bone. They don't actually feel like there's anything back there. They don't have a soft spot, or they don't have exposed area of their brain or anything like that. But it's a pathway basically from the outside through the mastoid bone, the bone behind the ear, to the inner ear.
So do you have to find a specific area? Is it pretty easy to find where the cochlea is?
It is. It's very reliable. There's some landmarks around that area, some important structures that thankfully we essentially never damage, but we have to be very careful when we go through there. But it takes about an hour, hour and a half, something like that. And you know, people go home the same day 95% of the time. So
when they leave the surgery, when they go home that evening, can they hear?
No. They cannot.
So what do you do?
Many times they hear worse, actually, out of that ear. And we usually don't turn the implant on for about 3 weeks. Gives enough time for the swelling of the tissues to go down so we can actually stick the external part via a magnet to the internal part that I implanted. And then from 3 weeks on, usually to about 3 to 6 months, they learn how to use it.
So are you learning how to re-listen? Does the voice sound different?
The voice sounds different, especially at first. Some people will say it sounds cartoonish or mechanical, but the brain does a fascinating job of smoothing that out over time, and most people get to a much better level. It's not normal hearing, but it's definitely effective hearing where they can use to communicate with people and enjoy some of the things they were not for a long time.
Do you have specialists that train the person on how to hear with a cochlear implant?
We do. I think the biggest thing is for most people just to talk to people and practice themselves. You know, if you're isolated and don't talk to anybody, that's a problem. So we want you talking to people, being interactive. But there are different places where we can send people. They do what's called ARO, so ear rehab, where we basically give them some tips on how to recognize words with this new device.
Just change somebody's life?
Very much so.
Yeah.
It's easily the most the satisfaction I get from anything I do is with a cochlear implant.
I would just think it would almost, I had goosebumps coming just thinking about how it would transform somebody's life to be able to suddenly be able to hear and know that that's going to be part of their new life.
Yeah, almost everybody gets better. Almost everybody does very well for the most part, and that's part of my job is to select the people who I think would do well. And they almost always tell me, I wish I'd have done this 10 or 15 years ago.
Yeah, and that's frequently like knee replacements. If I'd only done this 10 years ago, sort of thing.
It's amazing what people can adjust to from a poor quality of life standpoint, and they are just, they're very surprised at how they did, so poorly for so long.
Is there difficulty with a certain part of hearing after a cochlear implant, like going to a ball game where there's a lot of noise, or staying away from concerts or putting a plug in the ear to diffuse the sound.
Yeah, sound quality is not perfect. It's not normal. And so people will say that music, new music that they never heard especially, is not as nearly as enjoyable as it used to be. And then, hearing and noise is still always going to be a little bit of a struggle, but it improves for sure. It definitely improves in a quiet place like you and I are speaking right now, or at home, or at work generally. So there's some scenarios where it's really loud, or they really want to enjoy the quality of sound where they lose that. But the cochlear implants are making huge strides with some of that, and people are getting a lot of benefit.
Can you tell when somebody's walking to where, it looks to me like a cochlear implant is in the future of this person because the hearing aids are just not working?
Yeah, usually the writing is a little bit on the wall on some people, where I see that they've had they're maybe a younger person, maybe they're 40, 50, even 60 years old, and they have a lot of hearing loss and they're starting to struggle. It's at some point, I would suspect, because of natural age-related hearing loss, they'll be at a scenario where there'll be a cochlear implant candidate.
Jameson, Mattingly, you're a great teacher. Thank you for coming to the Dr. Bob Show. It's fabulous to know that hearing can be improved so well. It's all the time that we have this show. Remember, you got to have exercise in your life. You got to be eating properly. You've got to get 7.5 hours of sleep. And most of all, what is it you need? It's that laughter in your life. Spend some time laughing, giggling, having fun. You'll be healthier when you do, and people around you will be healthier.